It looks like we're ready to go. So let's start. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research, and thank you for coming today for our next in a series of seminars by the Institute in terms of members' research. I welcome our speaker, Dr. Catherine Burns from Systems Design Engineering, who will be speaking on understanding cognitive work in healthcare. Before we turn the mic over to Maher, who will introduce our speaker, I do have some important events that you should all know about. Tomorrow we're holding our annual career event in health informatics starting at 4:30 in this room. I invite all of you to come back tomorrow to join us for an hour of short presentations by representatives coming from industry and healthcare organizations, followed by a networking reception next door in 1301, where the representatives will be able to talk to you. They'll have little booths or tables set up, and it's really a fun event. It includes food and refreshments, so that's always an added encouragement. Great door prizes. I think there's an iPod with video capability, a really cool little video camera. So there's encouragements, all sorts of enticements, all sorts of reasons why to come. Unfortunately, I can't get one of the door prizes. Next up is we're holding a series of workshops entitled the eHealth Risk Workshops. They're back-to-back workshops, 1, 2, 3, that talk about risk management, security, and privacy. Those are being held here at the University of Waterloo from October the 19th to the 22nd. We're still taking registrations for those, so if you're interested, please register as soon as you can. That is followed by the Health Informatics Boot Camp at York University at the Schulich School of Business from November 3 to 5, and registration is open for that as well. In terms of upcoming seminars, our next Smarter Health seminar will be held October the 30th. Please note that that's a Friday from our usual Tuesday dates, monthly Tuesdays. And we are very pleased that Mr. Bill Tatham will be speaking on strategy for eHealth innovation. And lastly, our next research seminar will be held on Tuesday, November 10th, with Daniela O'Neill from, I think, the Department of Psychology speaking. So with that, if you have any questions about any of these events, please see me afterwards. And I'll now invite Maher to come up and introduce our speaker.
Good afternoon and welcome, everyone. It's my pleasure to introduce our guest speaker today, Catherine Burns, a professor in system design engineering at the University of Waterloo and the director of the Advanced Interface Design Lab. Dr. Burns' research examines user interface design, visualization, cognitive work analysis. Her work has been applied to healthcare, military systems, and many other areas. She is the author of over 200 publications and 4 books on interface design, best practices, and cognitive work analysis. Currently, she is working on teamwork models of healthcare applications to clinical pathways and diagnostic tools. Today, Catherine will talk about an important health informatics topic, understanding cognitive work in healthcare. Welcome, Catherine.
Thank you. Okay. Yeah, thank you for that very nice introduction. One of the things I want to do today is to convince you that this is an important topic in healthcare. So that's one of my objectives. What I'm going to talk to you about today is I'm going to talk to you about a method that we use in our research called cognitive work analysis, some of the past applications we've done with it, and then I'm going to extend it into how we're trying to extend it to teamwork. And this is a fairly new area for us, so it's still under development. And I know some of you are aware of cognitive work analysis, so that'll be a bit of a review for a couple of you here in the audience, but for the rest of you, I hope to kind of show you about this very interesting method that we're working on. Okay. So basically, cognitive work analysis is a method for trying to collect information that's going to help you in design. So it's a structured requirements gathering process. It's focused on trying to understand how people work and how people work at many different levels. Okay? And it's really been directed towards complex and safety-critical environments. And to be quite honest, it's a method that really hasn't been applied to healthcare until fairly recently. It really developed out of trying to understand how people work in environments like nuclear power plants. That was one of the first applications of it. Since then, military environments have adopted this method. It's fairly new that it's coming into healthcare, but it's actually, I think, a fairly useful method in several dimensions. So just to give you a bit of background in how the method is growing, and keeping in mind, if you kind of look at the examples I've got up here, none of these are healthcare examples. Okay, so I would say I can only think of about 3 or 4 people in the world that are really trying to use this in healthcare right now. But if you look certainly at military applications and process control applications, it's a method people have found very useful. And the reason they're finding it useful is that it's really looking at complex work. Okay, it's really looking at how people solve problems under stress, how people can solve problems in complex situations where they really need to understand a bunch of different relationships. Okay. And if I say, do we have those same characteristics in healthcare? I'd have to say yes. Okay, and that's why I think this method applies. Okay, so what you see up here is you see, obviously, quite a bit of adoption. The U.S. Department of Defense, okay, that's because of some very strong work coming out of the United States. There's also some very strong work coming out of Australia. DSTO is the Defense Science and Technology Organization in Australia. It's a very strong military environment, okay, where a lot of this is being applied towards things like control of uninhabited aerial vehicles, command and control type situations. Okay, it's also been used here in the petroleum industry, so include Canada. The ASM consortium is also a series of petrochemical companies, so think Honeywell, ExxonMobil, companies like that. Okay, they have a lot of the same concerns in terms as in healthcare, in that they want people to make the right decisions. They want people to catch their errors quickly. Okay? And they want them to make proactive solutions when things start to go wrong. Okay? And that's what we're trying to do with this method. So it's different. I come from a field called human factors engineering. Okay? And what we look in human factors engineering is we're always trying to study how people work in terms of deriving requirements so we can come up with better technologies that are going to help people. Okay. In terms of what we typically see, for those of you who aren't as common with human factors, typically in human factors engineering, people have like a single method, okay, and they use that to analyze the work. What's really different about cognitive work analysis is that it's trying to be multidimensional. Okay, it's saying there's a whole bunch of different aspects to how we look at human work and how we're going to use that. And we need to understand work in complex situations on a bunch of different dimensions so that we understand it correctly. And that's really what gives this method some robustness. Okay. If I were to say it has a point where it breaks down, it's that you see on my slide I've got 5 different dimensions, and I'm not even sure that's enough, okay, because the work gets that complex. So the kinds of things we're looking at with cognitive work analysis, first of all, by work domain relationships, we're really looking at structural or inherent complexities in the work. So things that are coming just from the nature of the work. So when we're talking about a nuclear power plant situation, we can be talking about the actual physics of controlling the nuclear reaction, the energy transfers through it. We're talking a healthcare type situation, we can talk about the actual complexities of human disease or resource management in a complex organization like a hospital. Okay, so just trying to understand the real complexities, not even really focusing too much on the users at this point, just what is inherently complex about what people have to do. Okay, task analysis is a fairly common human factors method, okay, and many people will just apply that as a sole method. Though I'm going to argue that you probably need to take a bunch of dimensions. But when we look at task analysis, we're looking at how people work through a problem, we're looking at a sequential breakdown of steps, and we're looking as we're going through that continually for how we can improve things. So are people repeating their tasks over and over again? Are there inefficiencies in the process? Are there workflow issues? Are there places where they're not getting the right information and they're not getting the information on time? So if you compare with what I talked about with the work domain relationships, we're really talking at this point much more user-centered. Okay, so if you've heard the terms user-centered design before, it's much closer tied to the task analysis idea. So different dimensions, the idea of looking at complexities in the environment and looking at how users work through them. When we talk about strategies analysis, we start talking about the fact that different kinds of users can actually approach their work in different ways. Okay, there's no one best way to approach work. We find that novice workers approach their work differently from expert workers. Expert workers will have shortcuts based on their experience that help them to do that work more effectively. But we also find things that people will manage their work differently under different situations. Okay, as people's workload increase, we see things like people shed tasks, we see prioritization, we see different work strategies happening. Okay, so that's what happens in a strategies analysis. Social and organizational analysis is starting to look at the global macro organizational factors that can start to influence human work. So really at this point we want to step away from the individual and look at organizational constraints and some social interactions that can be affecting how they work. When we start looking at work competencies, we're just looking at the individual skills that person brings to bear. Them as a person, what are the actual requirements of the job in terms of the education level, in terms of technical competencies. Okay, so think of experience with computers or mobile devices, something like that. Possibly even as far as individual differences. Okay, psychological skills. Okay, I'm thinking at this point spatial recognition skills, memory skills, things like that. So at this point, we're looking at a very detailed individual level about what's required. Okay, so back to this idea that we're trying to, this approach look at work through multiple dimensions. Okay, we've got 5 up here. There might be more. Okay, but definitely this idea that if we need to take a multi-pronged approach in these complex work situations to understand it properly. Okay, so in the next few slides, I'm going to go through some of those major steps. I've probably already talked ahead of my slides because I have a tendency to do that, but we'll kind of move through them. So with work domain analysis, it's back to that idea of trying to understand what's complex about the world, about how it really works. And we're really, at this point, we're trying to develop models about how the world's working, and I like to kind of explain it as reverse engineering the world. Okay, so what's hard about it? Where are the complexities? Are there physical complexities that make it hard? Okay. Are there biological complexities that just make this a hard problem? Are there organizational aspects that are going to make this a hard problem? And what do people need to understand? Okay. What we tend to happen in these situations, when we get into these complex work environments, okay, including healthcare, is we're getting into situations where we actually need to move beyond a user-centered design process for a few key reasons. Okay? It's because the systems are so complex, we cannot just sit down with a user and ask them how it works. Okay, I often kind of tell the story that in some of these environments, if I sat down with 5 different users and asked them how things work, I would get 5 different answers. Okay, and that's the kind of problem that we're dealing with. It's not that our users are dumb by any means. Okay, it's that the world they're dealing with is complex, it's large, there are a lot of complex relationships, and there's a lot of good reasons why their understanding of it is based on their experience, the parts of the systems that they've experienced. Okay. So users may not fully understand the systems that they're working with, and that's just because they are so big, okay? And the other thing is they may not be able to articulate it. We actually see this sometimes with expert users, okay, is that they are so good with the system, okay? They've got such great little strategies for working through it, but if you actually ask them to tell you what it is, they're not always the best people to do that. Okay. The other thing we're looking at in complex relationships, we're always trying to develop this idea of trying to make our novice workers into expert workers. So we're trying to design for expertise. Okay? So we really want to be trying to capture what do those experts know about that system, okay, and know about how to work it, and how can we convey that to our novices. And that ends up being a really common theme through our research. So if anything, we're trying to not just develop a product that works, we're trying to develop a product that makes everybody work really, really well, I guess is probably the easiest way to say it. Okay, so if you think about mental models, trying to get mental models that are correct, okay, but make people experts at the same time. Okay, so generally a work domain analysis is pretty much an information requirements gathering process. It is based on a model, and you'll see some models coming up in some of the next slides. The models are multi-level, okay, there's just kind of a structure to the models. And as we work through it, we kind of work through the model, and at each layer of the model, we start extracting information requirements. Information requirements become design seeds that will later feed in towards the design, and that's the basic idea of how it works. Kind of the key aspects that we're kind of looking for is we're looking for things that make problems hard. Okay, so on the last 2 points there, places where variables interact or conflict. okay? Because that tends to be where the hard problems are. What happens in those situations? Those are the situations where people have to make a decision that's going to win on one dimension and lose on another dimension. So those are very interesting situations that we'll often try to highlight through the work. Okay? And the other part we're trying to look for is things that end up being very complex because they're either long or bulky chains of reasoning. Okay? And that would be another aspect that we would try to hunt through in a design situation. Okay? We try to look for those, map them out, and they'd end up being something fairly critical as we follow through our design. Okay. In general, back to that idea that we're trying to look for what's going to make the work hard. So that's what we're going to want to support and try to make easier for people. So what I've got up here, just to show you how we use this, this is a nuclear power plant example. Okay, so and I'm kind of using it just because we've got a really good display contrast here is kind of why I pulled this one out. This is, in the nuclear power plant world, a fairly traditional display. Okay, and it's actually not a very bad display. It's actually a fairly good display. I've seen many worse, so I'm not out there trying to critique this display. But if you look at it, what we've got, if you see in gray, you'll see things that look like bow ties. Those are turbines. Okay, and all that is just a drawing of it. Okay, everything in all the blue lines are things like piping. And then you'll see things that little blue, again looking like little blue bow ties. They would be valves. Okay, they're indicated by valve codes and numbers. The main thing I want you to notice on this is that it's basically a drawing of the plant. Okay, there's a bunch of variables on it. In terms of how a user has to use this, though, there's certainly enough information to operate the plant from this, and people do. Okay, because plant operators are amazing. They're highly educated. Okay, they're very intelligent people. Okay, and they know how to work with these. Okay, they've usually gone through 8 to 10 years of training at their plant, learning how to use these. But from a user perspective, this really isn't a good display. Okay, because all the information that has to get in here in terms of showing people what's the state of the plant and how it works, getting a really quick answer of whether or not that plant's working correctly or not is hidden. It requires a lot of expertise to interpret this display. Okay. I don't know if anybody watching this knows any Norwegian, but there is Norwegian labeling, so it may not, it's even more confusing than intended. When we start trying to do a redesign based on a cognitive work analysis, we ended up with a display like this. Okay, so the things I want you to kind of notice on this is in the center of the display, it's done in very light gray. Okay, so I hope this is coming across okay over the web. I hope it is. But we still have the same information as before. Okay, we've got the basic drawing of the map of the plant. It looks a little bit different. We've used different coloring. We've restructured it a bit, but you still see the bow tie turbines in the middle there. So we still have the same information. But we've also tried to supplement the information with some key aspects to try to give this idea of giving people an overview of the health of the plant and helping them manage complex relationships. So what you should notice is that there's a lot more graphical information to it. Okay, because graphical information is very good for giving people kind of a quick view, okay, as opposed to giving them digital information, which they need to interpret and integrate. So you'll see graphs across the top of the display. You'll also see graphs across the bottom of the display. Graphs across the top, you'll see two things that look like, one is a pentagon and the other is a hexagon. Okay, geometry is good today. And the way those work is they really are pictures of plant views. Okay, so when the plant is operating correctly, it in a sense fills out the pentagon or the hexagon based on how many axes you have. Okay, so the basic shape of it is shown in the light gray. What's actually happening in the plant right now is shown with the black lines. Okay, so you get immediately a showing of current state versus desired state. Okay, so you can, even without being a power plant operator, I would think everybody in this room can kind of look at the first one and see the top one's down a little bit from the top. Look at the second one and see that VA3, valve 3, so we can pretend we're power plant operators, is a little bit high. It's immediately apparent. You don't need to look at a digital number. Ask yourself what's right, what's wrong, what's normal. It's that idea of trying to take something that's complex and integrate it visually in a way that people can interpret it very quickly. Okay? Not to say that an expert can't operate fine off of the previous display, and they do all the time. But you bring a novice in, like we are today, and you have to give them a quick answer, they're probably going to do better with this display. Okay. Just to give you a bit more, some of the designs on it. This display is what we'd call a salience controlled display. So we're trying to deliberately make problems apparent to people. So we're using our coloring and things very carefully. You'll notice the first turbine has red, so that's showing the turbine's having a problem. Okay, would have been available on the previous display, would have been a lot harder to see. Okay, and what you've got along the bottom of the display are just graphs of temperature and pressure as they move through the plant, which is also a clue to operators about whether or not that plant is operating correctly. Okay, so rather than seeing temperature digitally all the way through the plant on a map, we're showing it in a graph, which allows them to see. And actually the shape of those temperature fluctuations is important information to somebody operating this plant. Okay, so that's the basic idea of trying to capture complex relationships, make them easier for people to work with. Okay, so I talked a little bit about the turbine and the pentagon. Another kind of neat visual that we use an awful lot is the one in the middle. Okay, all this is seriously it is two vertical bar graph columns. Okay, for whatever variable we're using. We use this in a whole bunch of different areas. And then we visually connect it with a line across the top. And all that does is it starts to help us to see differences between the quantities. Okay? And as soon as we put the horizontal line across the top, it becomes visually very apparent. And just to kind of works like a seesaw in effect. And then to even highlight it even more, for those of you who are a little handy and like to do things around your home, we've built kind of what we call a bubble display on it. And that's what you see in the middle. And it works similarly to the bubble in your level, okay, in that it moves back and forth to show very small changes. Okay? It's that idea of trying to make very small changes visually apparent. You don't need to actually go back to the numbers to tell that those are at different levels. Okay? That's one of the things that we're trying to do. I just thought that was a neat display, so I like showing that one. Okay. So when we get into healthcare context, okay, it's health informatics. I'll get off the power plants. Okay, we're really dealing with a lot of the same problems. Okay, we're dealing with complex workspaces. Okay, in some cases, we're actually dealing with more complex workspaces because there are a lot of complexities to human biology and health that even aren't understood correctly yet. Okay, they're not understood fully. We don't have sensors through a patient the way we've got sensors through a plant. There's a lot of missing information. Okay, problems are easily just as difficult to understand. Okay, the interactions are very complex. Okay, there's a lot more social interactions and organizational interactions than we'd even see in the power plant situation. Okay, a lot more teamwork, more diverse teams. Okay, so still a very complex work environment. Trying to use some of the same ideas. What I'm going to go through now is I'm going to go through a healthcare project, okay, where we use cognitive work analysis, as well as some of the design ideas that we came up with it. Okay, in a couple of places, I'm going to point out some design ideas that are exactly the same in healthcare as they were in the power plant example. Okay, so I really wasn't going out of my way to bore you with the power plants. There was a point to it, that things apply across domains. Okay, so in this project, we worked with the University of Waterloo Heart Institute. Okay, this project was a couple years ago. Okay, so there are a few points where probably my memory is fading a little bit, but we were working with nursing coordinators. A nursing coordinator at the Heart Institute is an advanced practice nurse. Okay, so we've got a highly experienced nursing group here, okay, focused on cardiology and cardiac surgery. Okay, what's happening in this environment is they have a phone-in advice line that people call in when they've got heart problems, and they get directed to one of these nursing coordinators, okay, who will take the call on the floor, and they'll interrupt their work, they'll get paged, they'll go to the closest available phone, they'll start taking this call and giving this person advice. And the advice can be anything from, you better go to emergency now, to maybe giving them some advice on how to manage their medications better. Okay, so big range, they don't know what's coming up, and they are being interrupted through their work as they're doing it. So as we worked through this, we found that the nurses, they're not technically making a diagnosis, okay, but they are definitely doing, in effect, a triaging type situation. They need to understand the problem is urgent, okay, and they need to be able to send the problem to the right place and they do make some level of recommendations. Okay? They're working in a busy, interrupted environment. This causes interrupting them from their other work. It's mobile, okay? So they're not going back to the nursing station to check records. Okay? And it definitely is information impoverished. Okay? This was a very important factor they brought up. They're just talking to the person on the phone. They can't look at them. Okay? They can, okay, because it is auditory, they can tell things like shortness of breath over the phone. Okay? They cannot actually physically see the patient. Okay? So they really have to be asking the right questions of the patient at the right time to get the right story from them so that they can do this task. Okay? And the last point is because they're mobile, they're not at their desk, they can't really access a full set of previous records. In terms of the population, a very big range of experience. Okay, when we worked on this project, we had nursing coordinators who'd only done it for 1 or 2 months. Okay. There was not an extensive training program for this. Okay. We did have some that had done it for years. Okay, and they kind of apprentice with each other and they kind of talk, and that seemed to be the major way of knowledge transfer in this community. Range of comfort with computers and mobile devices. Okay, from people who had their own devices, were really keen on it, to people who'd rarely touched it and were really kind of a little hostile about it. Okay, so big range. And this was always kind of a concern as we were developing in this environment, that we come up with something that people will accept. Okay, given the range of experience and range of comfort with these kinds of technical solutions. Okay. Some basics on process. We went through standard interview processes, observations, incident reports. We would generate incidents and have them talk through it. Okay? And we'd talk to cardiologists and cardiac surgeons in terms of what they felt the questioning sequences should be, what are the clues they would be looking for. Okay? We mostly used the cognitive work analysis approach. Particularly in my lab, we did the cognitive work analysis. We had a team in Ottawa at Carleton University that really focused on cognitive task analysis methods. Okay, we did the first 3 phases, if I go back to the slide I showed you at the start. So we looked at work domain complexities, we looked at how people worked through their tasks, and we looked at the different strategies that they did. Okay, so we did not look at organizational factors. We did not look at individual task competencies. Okay, we felt that was probably out of scope. Probably practically it was out of our ability to access on this particular project. Okay, but in terms of developing an individual solution, these steps are often fairly effective and take you pretty far. Okay. Okay. In the interest of time, I think I'll move through that one. Okay. This is kind of an example of a call sequence that they would generate for us. Okay, so all I want you to really see from this is the idea that they're interacting with the patient, particularly in this case, they're doing something kind of interesting in terms of assessing pain. Okay, pain assessments are fairly tricky in that you're always looking for what's the anchor. Okay, and in this case, they're interested in, is the pain less or is it getting worse? Okay, so they're always looking for something to anchor it against. Okay, they're looking at how the pain is changing over time. Okay. And hopefully, the issue is that if the patient's getting better, the pain should be decreasing. If the pain's getting worse, that's a problem that they're looking for. Okay, so a lot of this call sequence is looking at pain. Okay. But pain ends up being kind of a balance factor, and you'll see that. Okay, so we ended up focusing, one of the things that we kind of pulled out as a complex relationship in this environment from the cognitive work analysis was this aspect of assessing pain, comparing pain, and understanding pain, because it ended up being a fairly good clue as far as the nurse coordinators were concerned as to whether or not the patient needed to come in. Okay, so they would tend to ask things like, well, is the pain like the pain before your operation? Yes or no? Is it like the pain after your operation? Okay, useful information to try to assess what might be the problem. If it's like before the operation, it might be a cardiac problem. Okay, if it's like after the operation, it might be an incisional problem. Is it improving? Is it getting worse? Trying to anchor it to some kind of marker that's going to work for that patient. Okay, so just to kind of give you an example, this is the kind of complex relationship we'd pull out with the cognitive work analysis, okay, and then we try to provide that in the decision support. Okay, This is just some general data of how they were using it, because we were kind of tracking how many people would focus on this relationship. Okay. Yeah. So in terms of what we would do with it, okay, that becomes our trigger to do some deeper analysis. Okay, so this led us to doing some research into pain management and cardiac care, talking to the cardiologists and cardiac surgeons. We're hearing this from the nurses. This is an issue they're looking for. Okay, how would you start to assess this? Trying to get that idea. Okay, starting to look at recovery pathways. Okay, what pain levels do you expect at certain points in a person's recovery as they move through? Okay, we ended up kind of building it into a tool that we provided for them. Okay, this idea of pain assessment and pain anchoring through it. Okay. This is kind of the basics of what you'd see at a work domain analysis. I'm not going to go through it in a great detail. What we're really trying to do in this is we're trying to look at the physiology of the situation. What does it mean to have a healthy patient? And most of this is focused on that. So if you kind of look at the top part, we usually look at goals at the top. We're usually looking at details at the bottom. But you're seeing the kind of goals that you kind of expect. So at the top left, our overall objective in systems like this is to maintain and improve patients' health. So you move down towards the bottom right, you're going to see like organ components and things like that that are involved in health type situations. Particularly in this case, heart and lungs being very key in cardiac situations. Okay, to flesh out the analysis more, healthcare situations are not just about patient health. Okay, they can be fairly important to understand institutional resources, especially in this situation where people are phoning in. Okay, when people are phoning in, trying to assess care, there are a lot of other dimensions coming into it. Okay, does that person have a car at home? Do they have somebody who can drive them? If I recommend they go to the hospital, can they actually get there? Okay, should I be actually telling them they don't have anybody to drive them? Maybe I should be telling them that they need to call an ambulance. Okay, do they have medications at home? Okay, so maybe they've been given something by the doctor, they haven't taken it. Maybe they can try that for tonight and call me again in the morning. What's accessible? What's available? Okay, some of the other dimensions of the problem. Okay, so these are the dimensions a bit outside of the actual physiology of the patient. Okay, we did proceed with a control task analysis on it. Mostly in this case, we were looking at information flow. Okay, so at what point does the nurse coordinator pass a problem forward to the cardiac surgeon or the cardiologist for advice on that problem? When do they get back to the patient? How often do they call the patient back to check on them? Would be the kinds of things we'd be looking through that. And one of the analyses that ended up being very interesting was the strategies analysis. Okay, so back to strategies analysis, we're dealing with the fact that if you give a bunch of people the same problem to solve, they will actually attack it in different ways under different situations. In this case, we're trying to figure those out, map them out, and if anything, start to understand how people transition and when people transition between strategies. Okay. So some of the things that these are some of the strategies that we found, but generally, to give you kind of a bit of background on it, talking to the nurses, they'll often start with an open-ended question to the patient. Tell me how it feels. And then based on the patient's ability to articulate, they're going to follow up on that. Okay, so they've got a few different strategies where they can start asking them for other symptoms. That's what I've got there for topographical search. Following through on it. They have an assessment strategy that they'd learned in nursing school that they call Old Car, which just gives them clues on how to proceed through it. So when did it start? Where is it? How long have you had it? Proceeding with that. Okay. Along the bottom, one of the things they can start doing is they can start probing along what we call a recovery pathway. So as people, are they getting better at the right expected rate? Okay, very important with cardiac patients because one of the goals is to get them up to a normal or close to normal cardiac workload, normal life, recovery type situation. Okay, and then one of the things we ended up providing in terms of information support was the idea of decision trees. I'm going to show that in the next couple slides. This was coming from the idea of trying to, in a decision tree, we're trying to capture the questioning strategies of expert nurses, making them available to nurses who maybe are not at the same expertise level or maybe haven't experienced that particular problem before, and in effect give them suggestions and guidance about what questions to ask when without restricting them. Okay. Okay, so I'm going to hop through this a little bit. Basically, you could consider this an ecological interface design approach. Our focus was visualizations and information support to help them ask the right questions at the right time. What you see up here is you see some of the basics of the decision trees. Okay, the way the screen looks a little funny is because this was implemented on a Palm tungsten. Okay, so it was a couple of years ago. Okay, so it's not wireless, it's not connected. But the way this decision tree works is trying to suggest a questioning strategy. It is not in any case restricting the nurse on her question. She does not have to follow these questions. She can hop through questions at any time, speed. She can leave them if she wants. Okay, behind each of the boxes, she can start to add information. Okay, there will be boxes that will ask her, is the patient running a temperature, ask more information about that. This all ends up going back into the record. Okay, so not restricting movement was something that was very key. Okay, we found from the strategy analysis that the nurses need to switch strategies on their time frame, not the tool can't be telling them when to be switching strategies. Okay, so it's mostly a suggestion. Okay, things that are really, really critical, okay, are highlighted in a different color. Back to that idea of trying to make the biggest problems most salient. Okay, a few other things, and I think we've got moving slides here. I'm going to try to pop them up. Whoa. Okay. I talked in strategies about the old car assessment strategy. Okay, so that's shown by the little red car on the box. So back to this idea that they can follow the decision trees if that's helping them. If at any point it's not, they've got a way to get out to the other strategy. Okay, trying to support strategy switching, which is showing up as something that was fairly important. Okay, the I for information. In that case, we're just trying to provide some kind of evidence-based information to support the decision making. Pop this up. Okay, a few key things here. Okay. Within the old car, what you see on the left is a screen for helping them in topological search. Okay, so if they've asked about, the chest, it pokes them for a few other questions they can ask. Is there pain in the arm? Is there pain in your shoulders? Is there pain in your neck? Trying to support that strategy as well as showing it visually. What's kind of interesting on the screen on the right is this back to that pain assessment idea that I talked about before. Okay, so trying to anchor the pain to previous experience, which is a strategy that we already know that they do. Okay, trying to show, if you see at the bottom, I told you back when we were looking at nuclear power plants that I was going to use that display again, and this is where we've used it again. Okay, it's flipped horizontally this time. It's that same idea of trying to balance the pain. Okay, show it on a pain scale, connect the graphics together, trying to make it as visible as possible as to whether or not there's a pain problem developing with this patient. Okay, so very much the same ideas can come across at times. Okay, and one of the nice things about this project that we need to do on all our projects is we had a technology acceptance plan with it. Okay, so the very first thing we did was we worked with the paper records they already had. Okay, we converted those records to electronic form, keeping them visually as similar as possible. Okay, so not a big change. We got them working with the electronic version of their paper records before we brought in any of our more advanced display ideas. Okay, the next stage, we started adding in our algorithm support, okay, our more advanced display ideas. Okay, and at this point, we were hoping they were already pretty much converted to using our product through the paper electronic record version. The next stage, what we started to do is we started to integrate our tools with other tools that would be useful to them in their job. Okay, so we added a drug reference tool to it. And we also started doing things like tutoring them on some of the other features of the device. Okay, so trying to get them to feel that it was worth their effort to carry this device around all day. Okay, phase 4, we started adding our more advanced display concepts. Okay, so maybe the things they'd be less comfortable with, things like the pain management idea, things that they hadn't seen before. Okay, and throughout we started building a tutorial program where a lot of the focus was on the usefulness. Okay, because this is something that we had from from working with the nurses was that we knew that our tool was going to be less efficient. Okay, so we knew that compared to taking records on a piece of paper at the phone, okay, it was going to take them longer because if you guys remember the POM, it was graffiti entry at that point, which I don't mind. I actually was pretty fluent in it for a while there. Okay, so we're talking graffiti entry. Okay, we're talking a mobile device. I still don't think there's a mobile device out there where people can enter things as quickly as they can on a piece of paper. So it's going to take them longer. Okay, they're going to have problems in that they're going to make errors they wouldn't make if they're handwriting. Okay, so it's going to have some annoyance factor to it. They're going to have to carry the thing around. Okay, it's a small device, but compared to carrying around a piece of paper, it's going to have a bit of overhead to that. Okay, so the best way to convince them that this was worth doing was to show longer-term usefulness of it. Okay, and a lot of the factors on that was showing things that they could access more things, they'd have a drug reference, they didn't have to read each other's handwriting. That was actually a very important factor. Okay, probably the overall selling point on the project. Longer-term medical records, the ability to look at calls, okay, over a longer period of time. What are people actually calling in over? What are the kind of advice that we're giving them? Okay, those kind of the longer-term advantages of having a system like this. Okay, in terms of, we had an evaluation phase. Okay, the kind of neat thing about this was our evaluation phase, we asked them to carry it around for 2 months, and they actually ended up using it for a year after that. Okay, so it was a really successful project from that perspective. The reason they ended up stopping using it was that they ended up upgrading their technology at the hospital. They came back to us for a revision, and our project had ended. So that is the problem of academic tool development, I think, is that we're not a company and we don't have Service Pack 2 available for updates. Okay, so as we were doing this, we had them focusing on their chest pain calls. We were documenting them. And they did reasonably well, but sometimes they didn't always. They missed a few times. We did look at patient outcomes. Okay, in terms of we had the patient's physician calling the patient back. Okay, after the call and trying to assess the appropriateness of the advice, as well as gauging the patient's experience with it. And we did not want a situation where the patient feels the nurse is so stilted and restricted in her advice back to them that they feel like they're talking to a computer. We still wanted the nurse to be working with the patient in an interactive and appropriate kind of manner. Okay. We had the nursing coordinators judge the usability of the tool. Okay, we logged the navigation data entry strategies. I don't think we ever really analyzed it, but it was available if we needed it. In terms of the advice, okay, is that it was quite successful. Okay, if I recall correctly, you'll see that it was considered appropriate in all but 2 calls, and as we tracked back through that, in the 2 calls where it wasn't appropriate, the nurses had not actually used the tool. So it was fairly successful. We got 34 out of 37 patients were satisfied with the experience. Okay, so we're optimistic that we were not interfering with the nurse-patient experience. We had a couple patients who didn't answer that question. Okay, and then we had one patient that wasn't satisfied, but it was a case where the nurse had deviated from the advice and the tool. Okay, so kind of tricky to analyze, but generally still very favorable. Okay, this is an example of the rating scale that they went through. Very simple. Okay, we weren't going to take up much more valuable nursing time in a complicated assessment. Okay, where we're going in the future, though, if you really think the methods I've shown you, and this is a feature of all of human factors engineering right now, it's been highly focused on individual performance. Okay, which is actually relatively, if you think about it, it's relatively rare. Okay, people are usually working in teams. So this is really a lot of focus of attention right now is to move forward to teams. Okay, and this is where we want to move forward with our work. Okay, and one of our current projects is, again, looking at clinical care pathways. So a bit of an extension of this, not necessarily cardiac, okay, but trying to look at how people move through the system, okay, how they recover, and how the different teams interact. Okay, we're trying to develop models in teamwork situations. Okay, this is some of the PhD work of one of my students right now. It's to look at different workspaces and teams. Okay, so in the first one, we've got a general workspace. What's happening in the next few slides is she's just identifying what members of the healthcare team are working in different parts of the space. Okay, the reason we're doing this is to see who's touching what parts of the space, what parts are different. Okay, as we're going that, we're looking at places where people have shared goals. What's interesting about teamwork is goals are sometimes shared and goals are sometimes not shared. Okay, sometimes people can have different goals, which can cause conflicts. We're looking at places where we've got shared processes or different processes. Okay. We're looking at how people transfer between different parts of the system. Okay. The other thing we're looking at is taking decision ladder models, which in the past have been for individuals, is what you're seeing with the cone there, and trying to extend them for a teamwork situation. This is a map of one cesarean section interaction that was given to us from the Ottawa Hospital, looking at the different people involved, the different interactions. Okay, and I think the complexity is kind of immediately apparent. Within each part of the cone, we've got kind of a simple model of the states that the individual is going through diagnostically, but all the arrows are showing the different places where information is transferring through the process. Processes in orange are showing processes that are happening synchronously at the same time, and we're trying to look at synchronous versus asynchronous teamwork in that case. Okay, a little bit of eye candy. The current clinical care pathway for cesarean births looks like this paper. Okay, complicated, very repetitive. We're developing some, these are iPhone type concepts that the students have been working on in terms of trying to transfer that information over. You'll see some of the same ideas you've seen in the previous displays. Okay, a patient side version of it. Okay, so giving the patient views of their own pathway. Okay, and so I'll wrap up at this point, but the main aspects for today are that cognitive work can lead to better designs, and that comes from developing a deeper understanding of the kind of work people are doing. In terms of where we want to go with this is we really need to do a lot more work in the direction of teamwork. Okay. I've got a lot of people to be thankful for helping out on this talk. Okay.
Thank you. Is my working here? It's working? Testing, there it is. Kathy, first of all, incredible the amount of stuff that you've covered here in this. Your team, the academic team, is that here as well? In other words,
Yeah.
people.
Okay, so Miriam Mashuri is a PhD student of mine. Dion Dujala and Candy Wong are actually undergraduate students, okay, who developed the iPhone concepts as undergraduate research. Kathy Montahan is nursing researcher at the University of Ottawa Hospital System, and Barb D'Entremont is an OB-GYN nurse at the Ottawa Hospital. So that's our current team.
I'll start with a comment, and I don't want to make sure if anybody wants to ask a question right away, they have a chance to. I want to start with a comment, and I want to go kind of backwards through. I took so many notes I couldn't possibly cover them, but back in, I think it was slide 23, and not necessarily have to go back to this. You talked about the way nurses have approached this in the past, and you had a little sequence between the dialogue between the nurse and the patient and a red box, okay? Don't worry about it. You had a red box which showed it. I would characterize that pathway as a nursing model. It's interesting.
Right.
Okay?
Yeah.
What you came up with in slide 25 was really a medical model. In other words, it's a way a physician would deal with it.
Agreed.
That's the big shift. I wonder if you want to comment on that. And then I want to go to I'll ask you to go to another slide. But really what's happened there is taking a person who is doing, in fact, a medical encounter as a nurse and turning into a person doing a medical encounter as a physician, except without all the training.
Legally, that could get really dangerous.
It's not a legal issue. It's the fact that in order to do a good job, the nurse had to adopt the thinking pathway of the physician.
We believe the expertise level is the same, okay? That they need to be understanding the disease in the same sort of way. They need to understand the urgency, the criticality, okay? They need to understand the effectiveness of the treatments, and that the best nurses and the most expert nurses will know that, and they develop it. okay? And that we need to be transferring that kind of knowledge down the chain, to be developing it more. And it just makes them better decision makers. Yeah.
So I think what's happening here is you're making your nurse coordinators into ice pick, I'll call it, nurse practitioners, adopting more of the medical model in that certain area.
Technically, they might actually, technically they might actually be nurse practitioner level nurses. So they are an advanced practice nurse.
Well, they weren't acting that role before, though, in that dialogue that you had. They were acting more of describe this relative before surgery, after surgery, rather than trying to describe it relative to the typical pain pathways that it goes through in a cardiac problem versus an incisional problem.
Yeah.
So that was interesting. You're moving between two models, and what you've created then is a process to move them into that model and use that model. If you would go to slide 29, I'm sorry to ask you to do that, but I want to point out something there that I think is crucial, and I'll ask others for questions in it. Okay, in slide 29, you have used this to essentially attempt the medical model here. In other words, you're asking about things like, how is the pain radiating?
Yeah.
Okay, so it's describing, that's a characteristic of angina versus incisional pain, is that radiation. I'm wondering about the expertise involved in this. I'll give you 2 or 3 examples. One, the way women present with angina is significantly different from the way men present with angina. Now, the jaw is on there. Jaw is an often presentation, but men also have that. I'm wondering, A, how you deal with that. B, if you look at statements like chest pain starting radiating down, it can go the other way too. Okay? So the characteristics of angina are in fact radiation, but the way the pain moves can be up or down. So I'm wondering about the expertise that was used to gain this. Was there in fact a cardiac clinician involved in that?
Yes, these were confirmed with the cardiologist and cardiac surgeon who are also on this team. Now, whether this is a complete list, I wouldn't be surprised if it isn't. There was a part of this I didn't go through, which was kind of an evidence point of care model that was running behind it as well. So if they wanted more information on things, it would give them summaries of current knowledge as well as a recommended set of research papers of well-run studies. So we did have a few dimensions on that, but yeah.
And of course, what you're doing here is empowering nurses, and you're empowering them in a different domain. Larry Weed was run out on a rail from Vermont, University of Vermont, because he created a system which was PROMIS, Problem-Oriented Medical Information System, that empowered the nurses, who then started correcting the doctors, and they didn't like that. So interestingly, this is occurring again, and there are sociological implications of this among the prerogatives of people within the health domain that, Have you seen any of that yet?
We haven't. In this case, not particularly, because this is a situation where the doctors are unavailable, so the nurse is really frontline. She could be taking this call in the middle of the night, so you want her making the best decision you can make. Where I see this actually being fairly effective is when we start looking at the teamwork situation. We look at things like electronic health records. All of a sudden, we've got a whole bunch of people from a whole bunch of different backgrounds who need to communicate about that state of the patient. So they need to be developing some kind of common model and common understanding, and it can't be parceled out into different communities of practice the same way.
Interestingly, Weed's future work, besides being run out of Vermont, has been on something called problem knowledge couplers, PKCs, and exactly does this kind of thing. And he's actually published as a company that does this. So there may be, in fact, be some interesting backgrounds. So I want to ask for questions so everybody else gets a chance to ask questions. Any? Okay, in the back we've got, give it to Martha.
Hi, I have a web question. How quickly did the nurses gain expertise with the new technology? And how would you characterize the time constraint of such learning curves with, let's say, the iPhone project?
Yeah, okay, well, first of all, the iPhone project is still too early on, so I don't have information on that. But in terms of getting the nurses experienced with it, they were working with the electronic forms of their current paper records probably 6 months before they were into the more advanced side of it. So they had an awful lot of practice with it. We also had a nurse coordinator on the project who served as a liaison member between the nurses and the team. So she did training with them. She would also handle problems they were having with it. So there was a lot of communication on that, and that was a very critical part of making this successful, to have somebody who could really be a liaison between the nursing community as well as the project team, and had her feet in both parts so we could really have a good interaction with them. But I'd say before they were fully using it, it's probably 6 months of phased-in usage. Yeah.
So I just want to make sure people have an opportunity. I'll go back to something else. And I think you had 2 tables, and one of them had the administrative, I think, across it, like purpose for administration.
Yeah.
And when you develop those tables, do you develop them with the involvement, for example, of administrative and other stakeholders, or how does that go about?
Okay. In this case, we did not have access at the in this project, we did not have access at that level. This was mostly developed off of talking to the nurses in terms of the kinds of questions in this area that they would ask of the patient when they're trying to assess what they should tell the patient to do.
Okay, so,
So
the
it's
reason I asked
fairly
that,
focused that way.
the reason I asked that, there are other
Yeah.
perspectives of administrators that they want to maintain and improve health. That's almost smothered in an apple pie.
Yeah.
And within available resources, they also have other issues related to getting the patient out of the hospital and all
That's
that
right.
kind of thing. So I was wondering
right.
exactly how that was developed.
Yeah. Yeah.
And-
And some of this is just insight and from other reading. I mean, I think the nurses did say, well, they don't actually worry about whether or not the hospital has rooms. They don't worry about some of these issues, but they do worry about if there's an emergency room close to the patient, can the patient drive themselves? Do they have a spouse there who can drive them? They'll worry about aspects like that. So.
The other one, really, I've always picked on the usability people, the people who look at usability
Yeah.
of systems, which you are part of. They've done now decades of research, but I've never seen an article on the lessons of usability research. Have you ever thought of publishing some of your reflections on what you've learned
Get an
along the
article?
way, so
Can I
all
have
the
a
rest of
book?
us can avail ourselves, because your time is too limited to allow all of us to work with you. So,
Yeah. I think it would take a book, Dominic.
next book
Yeah,
after
yeah.
your environmental interface.
Actually, you see it at the
ecological-
conferences. You will see people talking about lessons learned, and yeah.
The interesting thing, I don't know if you saw it or not, is we had Bill Stead here, was it last year now? Yeah, last year, and on our archivist's talk, I don't know if you had a chance to see that, but what he's done is taken some of the simple ideas of administrative dashboards and introduced them into the ICU.
Oh,
And
interesting.
that has,
Yeah.
it has been dramatically successful. I call it a 3M masterpiece. You may remember 3M one guy created those sticky notes,
Yeah.
and then they turned the phone after demand started increasing within the company over to, was it the director of marketing or something like that, and that person got so many calls, began to realize there was a thing. What Stead did in introducing this technology was, in fact, do such a good job that now he's under demand to get it everywhere. So the adoption cycle can be short-circuited when you have real demonstrations of effectiveness.
Yeah.
That's the big model.
Yeah.
He is being driven, I think, nuts, being pushed to bring that so successful technology
Yeah.
into other places.
Yeah.
So that's an
Yeah.
interesting
Oh,
thing.
look at that.
Other questions or comments? Just one or two I'll add here is when I see a project like this and knowing your brilliance, I wish that there was a possibility of bringing a team of people together on it.
Yeah.
From the group that Derek Kohler, for example, runs on the psychological aspects of decision support. The group that started at one time created a concept of a collaboration laboratory, a collaboratory kind of concept, where people in accounting were looking at the problem of interaction of groups, and this is where a team is important, where the team never meets each other, which creates all kinds of problems for truly cognitive interactions.
Yeah.
And there was a prof here that unfortunately went back to the States, but there's still residual interest in that. Of course, the usability people, the clinical people, and so on. This seems to cry for a network or strategic approach to this under the NSERC concepts, to really bring together the full set of
Yeah.
people. I
Yeah,
mean, this is
there's-
really incredible work.
There's a lot of
and-
expertise, and it's really diverse, and we don't communicate enough with each other, that's for sure. Yeah.
Any other comments, or? If not, well, I'll say then, thank you very much. Oh, is there? I'm sorry, there is from the back?
I have a question.
Oh, sorry. One other follow-up. Did the faculty try to find someone to upgrade the system once they found you had no more funding?
No, and that was a really disappointing aspect of this, okay, was that, I mean, that's really typical of academic projects, is when the funding's ended, the students have graduated, the project ends up being over. And that was very disappointing, because this could have been followed on and could have been developed further. Yeah. So, yeah, we had no follow-on.
I wonder if we couldn't find companies that might be interested. We just met
Yeah.
with IBM on Monday, and this type of approach might be very interesting from two aspects. One, the potential product aspects, but the other is you've defined a service.
Yeah, and actually, I think it's a waste of our research money, which is our taxpayer money, when we develop things that are successful and we don't follow through with them, right? I actually feel quite guilty and terrible about that. Actually, it's not good.
I guess Shirley's asked the question, what about Canada Health Infoway? It might be possible. I don't know what they're doing with their funding. One of the problems we've had is that this type of innovation is very difficult to fund.
Yeah.
But it may be a possibility in concert with other players, both small and large companies that might bring parts of this out. The concept of a service now, you've defined also a very comprehensive service, would certainly be interesting to the consulting industry, and IBM has both of those, but of course there are many other companies. So this is a methodology, a very challenging methodology, but nonetheless a methodology. And I would doubt that there's any consulting country in this company in this country that is delivering this type of approach to these problems. But rather it's offhand, try something, and so on. The final point I'll make is that the integration of whatever is done in these situations, and we've seen this with patient portals, with the rest of the clinical practice is crucial. So if patients do in fact read something in the surgical things and you do it differently, it won't work. There will be people who reject it. So I guess the other, maybe I'm going to comment on it, how are you going to, or what would you do in doing this again that would engage all of the stakeholders to actually change the clinical environment with this as an agent in the environment now?
Wow. Well, technologically, the very first thing is it needs to be networked. You know, at the moment it's just a standalone tool. Okay? But if you had this in a network kind of environment where, as part of it, the nurse can immediately contact the cardiac team, okay, for additional advice, you add a lot of functionality and response to it. But I think your aspect of, like, how do you get the patient involved? Where do they see that, where they're at? And there's aspects of this that could be rejigged into a patient portal on how do I handle my cardiac symptoms. You know, and it could just be a different view that's tuned appropriately for that. But I mean, I'm a firm believer that patients are more educated all the time and want to take care of their health care. They're the first line of attack in catching things like human error in healthcare, you know, and they need to be empowered on it as well. So there's nothing to say it couldn't become a more integrated environment, not just a very standalone solution on one nurse's mobile device. Yeah.
Any final? Okay. Kathy, thank you very much. This is not the first time we've been able to thank you in this. I really appreciated the opportunity to hear this, and look forward to the next progress.
Great. Thank you.